For the AP technique and elbow imaging, we would have the patient sit at the end of the table with the arm extended and the internal extremity in the same plane. For the part position, we would need to extend the elbows to paint the hand and center the elbow joint to the IR. We would adjust the epicondyles to be equidistant from IR. We have the patient lean slightly laterally if necessary to ensure AP alignment. Our center area is perpendicular to the elbow joints. Our KBV 70. Our Kermer tower is 3 inches or 8 centimeters proximal and distal to the elbow joint and 1 inch or 2.5 centimeters on the sides. In lateral technique, in the elbow imaging, the patient must be seated at the end of the table with the elbow flexed 90 degrees. We have the patient to rest their humerus and forearm on the table and position the entire extremity in the same plane. Center the 90-degree flexed elbow joint to the IR and adjust the wrist and hand in lateral position. We would adjust the epicondyles perpendicular to the IR. Our center area is perpendicular to the elbow joint, and our Kermer tower and KBV are the same as the last technique. For the oblique, we have 2 sub-techniques. One is lateral and one is middle rotation. They are completely the same, but in one of them you rotate the arm laterally and the other one you rotate the arm medially. In this technique, we have to sit the patient at the end of the table with the arm extended and the entire extremity in the same plane. For the part position, we would need to extend the elbow super in the hand and then center the elbow joint to the IR. We would rotate the arm medially or laterally, and we would adjust the interior surface of the elbow or at the epicondyle to 45 degrees to the IR. Our essential is perpendicular to the IR and entering through the elbow joint. Our collimators are other elbow technique, 3 inches or 8 centimeters proximal and distal to the elbow joint and 1 inch or 2.5 centimeters on the side, and the KBP is 70. For the partial flexion technique in imaging of the elbow, we can position the arm in 2 ways. One is that our patient humor is resting on table, and the other one our patient forearm is resting on the table. For digital humor technique, we will place the humor on the table and support and elevate the forearm. We would put the hand, if possible, and place the IR under the elbow and center to the condyloid area of the humerus. For the proximal forearm position, we will place the dorsal surface of the forearm on the table and place the IR under the elbow and center for approximately 1 inch or 2.5 centimeters distal to the humeral epicondyle. Our collimator is 3 inches or 8 centimeters proximal and distal to the elbow joint and 1 inch or 2.5 centimeters on the sides, and our KBP is 70. In axiolateral Coyle method, we can take our imaging 2 ways. In one, our interest is the radial head, and the other one, our interest is the chronoid process. In both of them, the patient must be seated at the end of the table or through pain when imaging a traumatized elbow. For the part position, we will place the humerus elbow and the wrist on the table in the same plane. We will pronate the hand and place the IR under the elbow and center the elbow joint. When our interest is the radial head, we will flex the elbow 90 degrees, and when our interest is the chronoid process, we would flex the elbow 80 degrees. Our center area, when our interest is the radial head, is angled 4 to 5 degrees towards the shoulder when our patient is seated. When our patient is to pain, our center is angled 4 to 5 degrees cephalate and entering through the elbow joint. When our interest is the chronoid process, we would angle our central area 45 degrees away from the shoulder when the patient is seated and the way when the patient is to pain. Our central area is angled 4 to 5 degrees cephalate and entering through the elbow joint. Our collimator is 3 inches or 8 centimeters proximal and distal to the elbow joint and 1 inch or 2.5 centimeters on the side, and our KVP is 70.